Thank you. One quick note of history. Sincere thanks, Dr. Moran, for inviting me. You might not have known, but in 2013, 2014, my boss, Dr. O'Neill, sent Dr. Moran an email and said, as a personal favor, could I introduce you to Dee Dee? And could you please mentor her? And I have to say, she's opened so many doors for me. So Dr. Moran ever asked me to jump, my answer is going to be how high. So thank you so much for mentoring my career. So next 14 minutes and 40 seconds, I want to have some fun. These are my disclosures. Our goals are going to be, what have we learned about TMVR? I'm going to focus on valve and valve because we all do it and it's easier to understand. And then what are the future directions of it? Then we're going to move to tricuspids and deliberate what do we know and what have we learned about tricuspids, and then what is the future for tricuspid valve interventions. So lessons learned. When I was a fellow in 2013, we did the first TMVR in MAC. And the second patient actually had a valve embolization. The first case went great and we published it. So we got really scared. We were never going to have a valve embolization again. So patient number 3, we did not have a valve embolization. We were very successful, but we actually had critical outflow obstruction. And 72 hours later, the patient died, and that was an autopsy of the patient. From that day on, we realized how threatening TMVR could be. And in the white arrows, I show you the concept of neo-LVOT. It was on that autopsy, when we looked at it, we realized what the patient actually had as blood flow out of the valve. And in the dotted arrow, you see the native anterior mitral valve leaflet over the actual Tapered valve, too. That led to the development of the validation for LVOT prediction modeling and TMVR, and why we worry about neo-LVOT and LVOT obstruction. Unfortunately, it took us over 4.5 years. You know, David Wood gave an excellent lecture about his 6 years of his life. About 5 years of my life was on LVOT prediction modeling. It took us that long across 5 centers to collect 38 patients. Only 38 patients across 4.5 years to get that many patients. If you think about it right now, it's easier to enroll in Tendyne, M3, any other valve, but 38 patients over 4 years. And we had 7 critical LVOT obstructions. No clinical trial nowadays, whether it be the M3, Evoke, or any Tendyne device or Intrepid, should have LVOT obstruction. We accumulated 7, 5 were catastrophic. All 5 were in TMVR and max. We still had outflow gradients in valve and valve too. And what we found on the far left is you can see that neo-LVOT is less than 190. We had an increased exponential gradient for the outflow obstruction. So our lessons learned was that neo-LVOT was predictable. Over 5 years of data, we had a sensitivity of 100%. 190 was our cutoff that we did not go past, or we looked for alternative measures too. We also had excellent correlation. We already had pre and post CT data on these patients, and the R values were great, and that the pre and post CT showed a great correlation that this is all predictive and validated modeling. But the problem was, now if you look at 2022, 2021, 8 years later, what do we talk about? Durability. You heard this warning about already. Durability, and are we doing the right thing? Because if the valve is not durable, then why are we even doing valve and valve? Why don't we go back to surgery? And the other question is, what about bioprosthetic valve fracture now for mitrals, right? Keith Allen's an amazing surgeon. He has this great lecture about bioprosthetic valve fracture for mitral valve and valves too. And the lessons learned is that from the VIVID registry, Danny DeVere and his team showed that we don't look that good for mitral valve and valve. When we do a mitral TMVR valve and valve, we have almost like a 95% failure rate if we went by echocardiographic gradients. And our gradients are over 5, almost over 10 in majority of the valve and valve cases. And the thinking is because we had the wrong transcatheter heart valve implanted, or we have suboptimal expansion of the transcatheter heart valve leaflet. So these are failures. But the problem is that sometimes we make things more complex than it has to be. So we don't need to make things more complex. And if we think about TMVR valve and valve, we're talking about fracturing of valve and valve for a mitral position. We're thinking about, do we do it before, do we do it after? Why don't we go back to the root cause? Are we making everything too complex? Did we do it right the first time? And that's my future direction. So in 2019, this is probably the best paper that I've ever read, written by Dr. Durko and the team about surgical valves. Surgical valves are not standardized. That is shocking and wrong for our patients. And what we can actually learn is that in 2019 publication, there is no uniform IFU standardization for how surgical valve is designed, how the struts are designed, what the width of it is going to be, what the hemodynamics are. There's no standardized testing. And there's no labeling standardization too. Your 35 could be my 22. And this has persisted besides the surgeons asking for change. And that's just wrong. So we, as a Cardiovascular Masters Consortium with Richard Stagg, Bill O'Neill, Brian O'Neill, Tommy Karnasu, and Rand Chitwood, decided to do a head-to-head study looking at 3 surgical mitral valve prostheses and saying, well, if we take a fresh surgical valve, what is the actual value of that valve? Because the EOA charts and everything that we're given as physicians may or may not actually reflect what is true value because there's no standardization, there's no oversight. So we took 3 surgical valves as a future direction and did a head-to-head study, the Edwards Mitris, the Abbott Epic, and the Medtronic Mosaic, and we want to see what the bioprosthetic valve function was and the new surgical valve implanted, and then what the gradients would be, what the leaflet function was, and we also wanted to see what the outcome would be after a valve-in-valve TMVR, because in the VIVID registry, 95% of valve-in-valves failed. So is that true for a fresh surgical valve? We controlled for everything. We actually scanned all the preclinical animals beforehand, controlled for size by CT scan, controlled all the hemodynamics so we couldn't have an argument that the LVEF was bad on this one, it was good on the other one. We controlled for surgical skill. We controlled for implanter skill. Everybody was blinded to what valve was being implanted until the time of implantation too. So we also had autopsy and necropsy verification immediately after valve-in-valve implant to make sure that we're not actually seeing anything that's an artifact on imaging. Design was head-to-head comparison. Everything was bench tested for surgical valve opening diameters before the valve size was actually chosen. And we controlled for everything. Everybody was blinded. So what we did was we scanned 15 animals beforehand, 15 pigs. They were less than 5% anatomical variation for the left ventricle size, left atrial size, because that's transeptal crossing. Less than 5% variation for mitral annulus size by perimeter, by area, and by diameters. We had the same hemodynamic blood pressures in the actual case and the same heart rates too. When we did this, we selected the 25 Mitris, the 27 Epic, and the 27 Mosaic because when we did the internal bench testing, those are the ones that actually had the true diameters that looked the same by sizing. What we found was shocking. The labeled sizing or the labeling of these surgical valves, if you actually look at the IFU, they're not actually having millimeters after them. The labeling of 25, 27, 29, 31, 33 are misleading. In the top right-hand image, a 25 Epic only reaches 20 by 20 millimeters on the inside. It's not 25. 25 Mitris only reaches 23 by 23, and a 25 Mosaic only reaches 20 by 20. So we had this labeling chart, and this is nothing that the valve-in-valve actually shows too. So the labeling of surgical valves does not match what is actually the surgical valve size. It was never meant to say labeling is equal to size. And for all of us as clinicians, this is actually something we have to be aware of. There is never a millimeter on that IFU chart. When we looked at the valve from the side, the design of the valve is not standardized, which a 2019 document showed us. The Epic valve slopes into the ventricle on both sides with their struts. The Mitris is more columnar, and the Mosaic has a lopsided sloping in too. And the concept of the EOA, if you look at the top right-hand image from the American Society of Echo Guidelines, assumes that everything is a circle and tubular and symmetric. That EOA does not apply to surgical valves. Everything that we've been looking at is actually not valid because the tapered design was not taken into account for the EOA. So we actually had the wrong EOA surgical sizing charts when we're looking at these surgical valves. When we looked at the actual hemodynamics and the gradients, on the top row, we looked at the epicardial echo of all these freshly implanted surgical valves. And the tapered surgical valve designs actually limited the valve leaflet's opening ability. So Saiba was upset earlier with the live case because the leaflets were not really opening, and then Gilbert was saying it's because there was basilar restriction. We found the same effect on these surgical valves when they were freshly put in. We did CT confirmation and multiplanar view for 4D CT, and we found the same thing as echo. And the leaflets did not open because the legs were tapered. Conceptually, it might be hard to see on these images, so I'll show you the bottom left-hand image. If I put a tight resistance band around your ankles and made you go run, your legs are not going to reach full marathon sprint speed. That's what the surgical struts are doing when they're a tapered design and not columnar. So hemodynamically, why is that important? Because in the VIVID registry, we had 95% failure rate with a gradient over 5. Look at the tapered design right here. In the Epic with the most tapered design, a fresh surgical valve that was just implanted had a peak gradient of 9. Over 5 is going to be moderate mitral stenosis. The surgical valve leaflet opening area was smaller compared to the Mosaic and the Mitris, which had less tapered designs too. And then the surgical valve opening area was 1.8 on the Epic. 1.5 we all know is moderate mitral stenosis and severe mitral stenosis for TMVR valve-in-valve too. Strut widths also matter because we talked about neo-LVOT obstruction. We learned that neo-LVOT obstruction in TMVR was something with past lessons learned. The present lesson is that we always think the strut is going to be what causes the outflow obstruction. We could care less about the strut length because the strut doesn't prevent outflow going into the actual aorta. It's the distance between the struts. So if you look at the actual picture, how wide is the opening of the two struts? If the struts are fat, there's going to be a small opening area on the far left in the Epic. If the struts are skinny, there's a wide opening area before them. So wide struts are bad. So we did a valve-in-valve immediately after the surgical valve was done, after CT was done. And what we found was actually conformational changes actually happen. And if you have a tapered design, there's actually a waist in the transcatheter mitral valve-in-valve. All animals were implanted with the same 26 sapien 3 size by CT. On necropsy, you can still see the taper design, the atrial and the waist and the ventricular portion too. This corresponded with the valve-in-valve mitral gradients too. We also found that if the implanter cannot see the valve, it is hard to be accurate for the landing zone. So in the EPIC device, when you can see the core knots in the faint ring, Mosaic has actually struts in the distal ventricular struts. Mitras, you can see everything. They were more accurate in landing the actual valve at the correct place. So neo-LVOT obstruction risk is higher if we can't see where we're actually going. And that's important because that's not the struts, but we have no landmarks. Go human and go clinically. This data is now being validated by other clinical teams. And Minneapolis Heart just showed recently the hypoattenuated leaflet thickening that Dr. Dangus talked about this morning is very important, because if the frame is deformed, just like we have a stent, like a stent in the left main that is not fully open and is fractured, you're going to have higher leaflet failure. Now, future directions. This is where we got to talk. We have a heart team decision making for TAVR valve-in-valve, TAVR redo and everything. What about the first surgery? Because TMVR valve-in-valve impacts all of us. All of our patients are outliving our bioprosthetic valves. Our bioprosthetic valves are supposed to be 10 years old. Patients are outliving them. So at the time of the first surgical implant, should we be saying, what valve should we have? Because I want a 29 sapien 3 for my mitral position and not a 20 sapien 3. Because what I'm showing you are 3 different patients that are real world that we've done TMVR valve-in-valve, and I can tell you those gradients were all above 10. So let's pivot now and do tricuspid. There's not many past lessons learned. Let's see what we're learning currently right now and what the future directions are going to be. So what we had to understand with tricuspid is there's a roadmap. We have a roadmap, meaning there's how do we get into the RV? And that's something we don't know, and we've always ignored because we care less about that because it's a tricuspid. Well, something's very important is it takes the veins to the right atrium, veins to the right atrium to tricuspid annulus. Then also there's pacer wire interference, and there's you have to reverse and come out of the whole actual heart too without causing a perforation in the RV. There's a lot of complexities. And one thing we don't think about in 3-dimensional modeling and on 2-dimensional echo or fluoroscopy is that the track from the IVC to the RA to the SVC is angulated. It is not planar. So an AP view will not show you everything. It could be angulated obtuse or acute angle too. The IVC to the RA angle is actually also different too. You can have a pivot point problem when the IVC has a very obtuse angle, and the far right, if the IVC is very wide, you won't have a pivot angulation. Same thing with the SVC going to the right atrium. From the SVC to the right atrium, you could have angulation and pivot problems too. And none of these are taken into account when we do a delivery system because everybody was obsessed with tricuspid annulus, but not the actual track and how to get into the right ventricle. Maybe, just maybe, this will explain why we have so many variations in the right ventricular lead placements, and that's why we have so much TR, because our EP folks are encountering this difficulty. Or it could just be because our EP folks are not using imaging to put the pacer wires in. But in real world, these are 3 patients that we've done for TR cases. And what I've shown you the surgeon's view on TEE. Patient on the far left, the IVC is at 6 p.m. If I'm doing this patient, I'm going to need a lot of primary and secondary flux to get into right atrium. Patient in the middle here, actually the IVC and right atrium are only a little bit offset. Patient on the far right is actually straight, and the IVC goes into the right atrium. Patient on the far right actually has severe tricuspid regurgitation and will be very easy to maneuver. Close your eyes, and here. All right, next slide. So the future is going to be transcatheter tricuspid valve replacement. So this is our TriScend or EVOKE experience at Henry Ford Hospital. And what we first do is you can see a delivery system is a transfemoral approach from the RV. We do the pigtail RV angiogram. Look at delivery system with the pigtail with the actual wire going to the PA. You can see how difficult it is to maneuver. The sheath is fairly long, but once we get coaxiality, it's really good. When the device is implanted, you have no reflux of contrast into the right atrium, and it's a beautiful result. So that's the future of tricuspid valve therapies. But sometimes the IVC is not favorable for a transfemoral approach. And so next thing you got to think about is, what the IJ? Is an IJ possible? Because in the far right image, you can see the IVC comes off at 4 p.m. And when I have a delivery system coming in, it goes towards the fossa, wanting to do a mitral clip. This is tricuspid. However, the SVC is a straighter shot in the right atrium. So I'm very excited to share with you, these are our first 4 US LUx transcatheter tricuspid implants that we've done in the United States. And these are actually an IJ approach first ever tricuspid valve replacement. You can see the IJ going in here. The 2 tabs are opened up under the anterior and the posterior leaflets, actually anterior-lateral leaflets. As a septal anchoring mechanism that we can actually see the anchoring going to the interventricular septum. And here you can see the anchor going to the interventricular septum to actually cross. And it actually has an anchor mechanism that actually is implanted into the septal portion. So there's 2 anchoring mechanisms. And this is our case last night. a very successful LUx implant, the fourth one in the US. There's absolutely no TR, great RV function afterwards. And on 3D, you can see the LUx valve in the right atrium looking great. RV function was severe before, severe afterwards, but they did not require any milrinone, which is pretty amazing. Okay, my last slide is this. Advances in mitral tricuspid imaging. It's actually honestly not about imaging. It's about learning anatomy as physicians at the heart team. For valve-in-valve TMVR, checkbox. We already have a validated protocol for LVOT prediction modeling. We know how to do it. The problem in the future questions are we need standardization of surgical prosthesis design and labeling. We don't have that. And the question is, for the future as a group, should we have a shared decision-making at the time of the first surgical mitral valve implantation? Because it definitely impacts the valve-in-valve. Moving forward, imaging for the right heart. It's not about the tricuspid. Could care less about the right tricuspid. It's actually the right heart because all the anatomy is important. We have a lot to do. We have to learn the anatomy to the right heart from the IJ and from the femoral vein. And that might help us optimize pacemaker implants in the future because at least half of our patients for TR have pacemakers. And in our future, we have a lot of room to develop for improving our delivery systems. A lot of our delivery systems right now are actually not good enough for our tricuspid patients. So with that, thank you for your patience. Appreciate it.
Very much. Before live case, I'd ask Dr. David Adams a couple of questions about a lot about imaging regarding transcatheter. Do you think such sophisticated imaging are necessary for surgical procedures?
Oh, we're not surprised at all. This is old news in surgery. We, come to these meetings sometimes and we rediscover what we've known in surgery for years and years. And Dee Dee, I like the numbers. There are a number of papers about this that have been there are not a lot of literature and a lot of presentations about this. These numbers were never meant to go one size versus another. So we should be really careful about that because what you don't know, because you couldn't know, because you haven't implanted thousands of these things, is that the numbers are, and I don't know what led to all of that confusion, but the numbers, we all know this, and I'll give you an example. We put in lots of epic valves, and we put in mitrous valves as well. I stopped putting in the prior generation Edwards Magna Ease valve years and years ago. So the first decision you have to understand about valve implantation in surgery has nothing to do with whether you can have a valve in valve. You need to survive that day. These valves have very different implantation characteristics. And the only thing we can determine about implantation characteristics is when we're actually there and we've taken leaflets out and we look at whatever pathology we've had to leave behind. And then we have to decide, and I'll give you an example in the mitral position since she showed the mitral valves. Oftentimes, if you're doing a mitral valve replacement for the right reason, not for prolapse, for rheumatic disease, inflammatory heart disease, for radiation, for things that are really complicated, you need to make decisions about, can I fit a valve in the orifice? We can't enlarge the mitral annulus. You can't do that without coming back to the outflow tract side. You're not going to do that in these little old ladies where you need to do that. So then you need to think about, can I put part of the valve and really put it supraannular? Let one of the struts actually ride. Just make sure it gets in the orifice and be above. That's where an epic valve, for example, you complain about the tilt for 10 years from now. I will tell you that little minor tilt can help you a lot if you're having to oversize a prosthesis. So there are then there are subtleties about the sewing cuff. So there's not something we can do a whole lecture about how we pick valve prostheses. But yeah, the message is, particularly if you're with experienced surgeons, they're trying to put the largest valve they can safely. It does have to be safe. There is a mortality risk with mitral valve replacement, and one of those risks relates to annular disruption. So you have to be very thoughtful about it. In terms of the outflow tract, same rules. I don't care what your strut shape is. You don't get outflow tract obstruction if you orient the valve correctly. And so I think there are a lot of subtleties we couldn't talk about here that lead to the bigger picture of valve replacement.